Good morning, good evening, good afternoon, everyone. Hello to the and welcome to the Med News Week keynote conference. Where our goal is to bring you the most cutting edge information from the medicine's global leaders. I'm Raj Rangraj, and I'll be your host today. Before we begin, I want to first acknowledge that the great team that helps to make this event a reality. Our founders are two internationally recognized researchers, Dr. Jan Leifman and Dr. Chandler Park, who is also the president of Kentucky ESCO. Our associate directors include Balasubramaniam, Helena Koloma, Muskan Joshi, Gayatri Pramil Menon. Our director of research and scholarship is Viviana Cortiana. Our managers include Alexandra Wande Geft, Ahmad Aziz, and Gina Gezel. Our educational committee includes Rabah Babas, Blaise Bozers, Harshal Choria, Taha Kasim Dodwala, Jade Gamble, Kennedy Todo, Ritika, Shivika Kanan, Dr. Shashikant, Gina Khasavne, Soumya Nader, Ishan, Liana Rafik, me, myself, Aishwarya Singh, Adit, Riya Vaishnav, Harshita Vallabhenini, Imad bin Zahid. We also want to thank our partners, the National Society of High School Scholars, I3 Health, MDPI Cancers, Oncology and Therapeutic Advances in Medical Oncology. Now, it is my honor to introduce our keynote speaker, Dr. Elad Sharon. Dr. Sharon is the Clinical and the Translational Director of Immunotherapy Toxicity Program at the Dana-Farber Cancer Institute and an Associate Professor of Medicine at the Harvard Medical School. Roles he began in August 2023. Prior to his current positions, Dr. Sharon held pivotal roles at National Cancer Institute's Cancer Therapy Evaluation Program, the CTEP, and he served as an attending physician in the NCI's Developmental Therapeutics Clinic, the DTC. During his time at the NCI, he helped co-direct the immunotherapy drug developmental portfolio for CTEP, overseeing over clinical trials for which the NCI served as the sponsor in collaboration with the industry and the academic colleagues. CTEP is the largest government sponsor of the clinical trials globally, enrolling around 20,000 patients on NCI-sponsored clinical trials with trial sites throughout the United States and around the globe. His tenure at the NCI involved complementing industry efforts with public health-oriented drug developmental, bringing novel clinical trials to both academic and community oncology settings. Dr. Sharon helped shape innovative, practice-challenging clinical trials, resulting in numerous FDA approvals for both rare and common tumors with a variety of agents under his purview. Dr. Sharon's focus on biomarker-driven translationary research, translationary rich clinical trial designs leverage the assets of NCI, the Frederick National Lab for Cancer Research, and academic partners in early phase clinical trial networks. His collaborative efforts with major stakeholders, companies, advocacy organizations, and researchers proved him with unique insights into successful translation of research into clinical practice. Recognizing the importance of balancing therapeutic efficiency with a thorough understanding of toxicity, Dr. Sharon initiated several national projects to study the adverse effects of cancer immunotherapy. He originated the NCI Alliance Immune-Related Adverse Event Biorepository, which offers the researchers access to clinically annotated specimens from patients experiences these kinds of events. In his current role at Dana-Farber and Harvard Medical School, he's pioneering new ways to identify, manage, treat, and mitigate immune-mediated adverse reaction caused by immunotherapy agents. He is committed to improve patient outcomes by integrating clinical insights with translational research. bridging the gap between the clinical practice and the research to ensure the therapeutic strategies are both effective and safe. In addition, his continuing drug development efforts primarily focused on the field of cancer immunotherapy. Through fostering collaborations and utilizing innovative tools, Dr. Sharon aims to enhance the therapeutic landscape for cancer patients, driving forward the understanding and management of the cancer immunology and immunotherapy related toxicities. With that, I would like to welcome Dr. Sharon. The floor is now yours.
Thanks so much for that kind introduction, and thanks again to the organizers for inviting me to speak to this wonderful community of learners. So the work, as mentioned, that I focus on is actually at the intersection of cancer, autoimmunity, and immunology. I happen to be a little bit more clinically focused, but there is a lot of translational work that needs to occur in order for us to better understand what's happening at the immune-host interface and how we can actually help patients and improve outcomes. And that's certainly been my major interest over the past several years since when I was in the NCI, and now that I'm at Harvard Medical School and Dana-Farber. Cancer, of course, has actually developed exponentially in terms of benefits that we've been able to get from clinical trials due to targeted therapies and immunotherapy over the past 2 decades. This is actually a cartoon from 2015 from The Economist, in which they sort of showed the difference that immunotherapy essentially is making. You've got the 4 horsemen of the apocalypse, at least for cancer, aided now by a 5th of immunotherapy attacking this cancer cell, and that was the year after pembrolizumab and nivolumab had actually been approved for melanoma, and in that year, 2015, both drugs, PD-1 inhibitors, got approved also for patients with non-small cell lung cancer by the FDA. Now, when we think about immunotherapy, we think actually about a lot of different potential things. There are a lot of different meanings to that statement. In the world of cancer, though, immune intervention of cancer takes several different forms. So obviously, there are vaccines, and presumably when we're conducting work with vaccines for immune intervention, we're thinking about defined antigens that the cancer has that we are using as a therapeutic cancer vaccine. Of course, there are some preventative cancer vaccines as well that have actually been very successful, including the hepatitis B vaccine and the HPV vaccine. There are also cytokines that have been used to promote T cell activation, proliferation, and function. And the oldest of those is interleukin-2, which was approved in the 1980s and used in melanoma and renal cell cancers. We have been exploring the use of T cell co-stimulatory signals. None of those have actually been approved, but blocking T cell inhibitory signals, that's where most immunotherapy is actually being utilized today, and certainly in the clinical setting with CTLA-4, PD-1, PD-L1, and LAG-3 inhibition. There's adoptively transferred antigen-specific T cells. That's adoptive cell therapy. A lot of times people think about CAR cell therapy, CAR T cell therapy, but there are other kinds of similar adoptively transferred T cells, including tumor-infiltrating lymphocytes. That was approved in 2024 by the US FDA for the treatment of patients with melanoma, and there are also TCR-specific treatments that have been looked at. And there are bispecific antibodies that have been used to sort of mimic that approach, using a CD3 construct with a TCR, in the case of uveal melanoma, by a drug called tebentafusp, and also other agents that combine a CD3 and a CD20 to mimic something that rituximab does, anti-CD20 antibodies. But using the power of a T cell in order to eradicate, in that case, lymphoma cells for the most part. We can also give antibodies, and sometimes that's what people think of CDC or ADCC, antibody-mediated destruction of cancer cells. We can activate NK cells. That's an area of ongoing and interesting research. And then people are using fecal microbiota transplants for patients with cancer to some good effect and some interesting publications that have come out. But for the most part, much of what we've been doing and much of what we call immunotherapy over the past couple of decades has focused on immune checkpoint inhibitors. And that's where I'll focus actually the rest of this talk, at least. So PD-1 is actually the area that's of the greatest interest for immunotherapy at this point. The biological function and details of PD-1 are here. PD-1 essentially is a marker of activation of T cells. So sometimes we think about T cells that are actually expressing PD-1 as being exhausted. That's something that is mentioned again and again. But of course, what the immune system has to do is it actually has to allow for an attenuation of effect, because an immune response is actually very dangerous potentially to the body. That's why autoimmunity is a major issue in healthcare, obviously, in controlling things like multiple sclerosis and inflammatory bowel disease. And through evolution, the immune system essentially, and you'll see this also with CTLA-4, the immune system tends to prioritize attenuating the immune response over overly activating the immune response. And so, as noted again, PD-1, or it stands for programmed cell death 1, that's the receptor that's here on a T cell, interacts with two different ligands, PDL1 and PDL2. The expression of interferon gamma in the tumor microenvironment leads to upregulation in normal cells of PDL1, and that again attenuates the immune response. So if you have cells that are actually able to respond to interferon gamma, then the mere expression of interferon gamma in that microenvironment leads to PDL1 expression on the surface of those cells, whether they be cancer or other normal cells. And that actually leads to activated T cells to attenuate their activity. And there's something of a dance that actually occurs between infiltrating T cells and the surrounding microenvironment, where the T cell expresses interferon gamma. That leads to expression of PDL1 in that microenvironment, which then, if the PD-1 receptor is expressed on those T cells, leads to attenuation of the T cell response. That leads to decreased interferon gamma production, which then leads to decreased PDL1 expression in that microenvironment. And these things just basically go on and off in a cycle for some time until there's enough of a response or enough of a signal produced so that the immune system, if there is a threat, can actually eradicate that threat. Of note, and I'll discuss CTLA-4 briefly shortly, but PD-1 is more broadly expressed than CTLA-4. It can actually be induced on B cells and NK cells as well. There are two ligands, like I mentioned, PDL1 and PDL2. It turns out clinically that PDL1 happens to be that which is much more important. But initially, through chronic antigen exposure, PD-1 and PDL1 were actually thought to be much more important in infectious disease. And in fact, one of the individuals who is on the PDL1 patent is Rafi Ahmed and actually Dan Barber, his postdoc, both of whom were actually in infectious disease labs and had been looking for potential uses of blockade of PD-1 and PDL1 for those patients that were suffering from chronic infections. And there's a story about that that we'll get into later. So PD-1 obviously can shift the balance from T cell activation to tolerance at early stages in T cell response to antigen within secondary lymphoid tissues. The thing, obviously, with PD-1 and CTLA-4 and all these different immune checkpoints is that what they do affects not just responses of the immune system to a cancer, but also potentially responses to normal tissue. And these adverse events that can occur can actually be dangerous and deadly for a patient. They can occur at any time, but there are some regular expected time frames where certain adverse events occur. These obviously can get modified, and I'll discuss that later, by concomitant medications, for instance, chemotherapy or the use of dual anti-checkpoint inhibitor therapy. And that can actually change the response, not only for the cancer, but also the emergence of these immune-related adverse events. Again, IRAEs, they can occur almost anywhere in the body. Depending on the regimen used, this can occur in up to 50%, 59% of patients. Some of these are actually fatal. Apologies. Most of them are low grade and disrupting of quality of life, but they can also, unfortunately, be long lasting. For some patients. And IRAEs in particular are actually quite different from chemotherapy toxicities, in particular because immune-related adverse events are usually mediated essentially by the immune system directly by the T cells contained therein. And these individuals that are suffering from immune-related adverse events caused by their immune system sometimes have these adverse events for years later. Once the fire gets started, the immune system can carry it forward for quite a long time. But there are some predictable areas that are at least a little bit more common than others. Some things are actually, fairly rare, like myocarditis, type 1 diabetes that can occur as a result of the use of these checkpoint inhibitors. But pneumonitis, thyroiditis, colitis, hepatitis, these are significantly more common and issues that must be addressed carefully. Otherwise, patients that aren't being properly monitored can die of easily preventable adverse events that occur as a result of this therapy. Now, why is this important, particularly for a general audience of individuals that might not necessarily be oncologists, is that again, this other modality of therapy, this use of the immune system to treat patients with cancer, ends up affecting quite a few fields. This is because there are many different indications that have immune checkpoint inhibitors as part of the armamentarium, therapeutic armamentarium for their cancers. When I started this particular slide, I sort of listed all the different cancers where I had seen some activity in the literature or on our own trials with immune checkpoint inhibitors, and I put things red, bolded, and underlined as there was an FDA approval for these agents or for these entities rather. And I started out in 2016, I think, with this slide, so that we only had melanoma, renal cell cancer, and non-small cell lung cancer. And as time has gone on, you can see that the list was actually the same, but the color and bolding and underlining of the text changed. And there are now 25 different separate entities for which there are approvals for immune checkpoint inhibitors in the US by the US FDA, and obviously globally similar to that. 41 different unique settings and 91 or over 90 certainly approvals that exist, including nasopharyngeal cancer and rare entities like alveolar soft part sarcoma. Lots of different things obviously can have an effect on whether or not a patient has either a positive or a negative outcome to immune checkpoint inhibitors or any kind of immune intervention. There can be issues related to their own genetics, lifetime environmental exposures, the TCR repertoire perhaps that they're born with, carcinogenesis, the tumor evolution, and how the patient presents, obviously, for treatment at what stage and what setting. But the questions sort of come down to what the T cell tumor or stromal factors might exist at the time of treatment, how many T cells, what type, tumor antigens or neoantigens, what the immune system is actually responding to, and areas in the tumor microenvironment where that means to Treg cells or T cell regulatory T cells that are present, or myeloid-derived suppressor cells that might actually be present, all of which can potentially be manipulated down the line. And these are areas of active interest and research. Now, again, when I say that the toxicity is actually really important and very important actually to evaluate, there's data behind that. So we did a trial some years ago called the DART trial, the S1609 trial, that the NCI supervised when I was there. We enrolled about 800 patients on a 53 cohort basket trial for patients with rare cancers. These are sometimes entities that only have a few hundred incident cases in the US every year, but we created actual cohorts specifically for those patients to be treated with nivolumab and ipilimumab. And what emerged essentially was a trial that not only had 53 small trials in one, but also treatment that we were able then to look at from a pan-cancer perspective. So technically it wasn't a pan-cancer trial, so no colon cancer or lung cancer patients were on this trial, but there's such diversity of different kinds of cancers that were actually included on this trial that we were able to come to some conclusions that we thought were relevant for any cancer patient treated with immunotherapy. And so this is one such example where we looked at patients indexed by their first cycle toxicity, what they had in the first cycle, meaning day 42 at the end of the first cycle, in this case, was because ipilimumab was given at 1 milligram per kilogram every 6 weeks and nivolumab every 2 weeks, so at 6 weeks, and looked to see what happened to those individuals based on the grading of the immune-related adverse event that they had in that first cycle in terms of survival. And you might be able to see this. It might be a little small for the screen. This is published in JNCI 2024, where we looked at those patients in blue line that had a grade 1 or 2 immune-related adverse event in that first cycle versus the black line, which is no immune-related adverse event, versus the red line, which was a grade 3 to 4 immune-related adverse event, a worse immune-related adverse event. And you can see that there's a clear Kaplan-Meier curve showing that those individuals that had a grade 1 or 2 immune-related adverse event had better survival than those that had none. And in turn, those individuals had better survival than those that had grade 3 or 4 immune-related adverse events. And so we have various theories as to why that might be. The suggestion, is, at least that I have, would be that those individuals that have grade 1 or 2 immune-related adverse events have better survival, in part because they are able to show or exhibit to us in evaluating them that they have an immune system that can be activated. So it's functional enough to actually be activated, and that correlates with benefit that potentially could be offered. And that could explain why those patients do better than those with no immune-related adverse events. But those patients with grade 3 or 4 more severe immune-related adverse events then doing worse. Why could that? What is the reason for that? So those individuals typically have to stop therapy because of their immune-related adverse event, and they also more commonly need some sort of immunosuppressant to be administered. So that could be steroids, that could be infliximab, that could be other agents, and those individuals, again, they do worse, have a shorter survival, and we're analyzing those data going forward, but that's at least the hypothesis that we're looking at. What we have when we look at immune-related adverse events in general is we are using the human essentially as a knockout animal model. So IRAEs, they can have relevance, as noted, for mitigation of the AE, but also for the study of the autoimmune disease that is a cognate for that AE. Treatment and management of an adverse event caused by immune checkpoint inhibitors can teach us something about both the autoimmune disorder and vice versa. And we can also get something from samples from those individuals, and that's the focus, or a focus, of my research. So here's an example. I was not involved with this, but it's an example, I think, of what you can do with immune checkpoint inhibitors and ICI-related adverse events. Published in November 2016, this Douglas et al. Paper about fulminant myocarditis in patients that had received PD-1 and CTLA-4. There were 2 individuals that are included in this brief report. And interestingly, those individuals who died as a result of fulminant myocarditis had infiltration, both of their myocardium and their skeletal muscle, with lymphocytes. They did not have a similar infiltration of smooth muscle, which was shown here on panel F. And they took in the or placed in the appendix an analysis, at least of one of the patient's clones that were present in the heart. So they took the top 10 clones, they made them color coded, as you can see here, in terms of the cumulative percentage of templates that were actually present in the heart. And then they looked to see where else they would find these exact same clones. So the immune infiltrate that you see here in the top 10 clones were present throughout skeletal muscle in the autopsy specimens that were obtained. And they were also present in the pre-treatment prior to administration of the PD-1 and CTLA-4 pre-treatment specimens, and at a greater degree at the autopsy of the tumor specimen as well. But obviously, these TCRs were able or capable of responding to some antigen that was present in the heart and skeletal muscle, and they obviously found much more fruit for them to attack or fruitful time in the heart, unfortunately, for this individual patient. And that's the danger, obviously, with these adverse events, that the immune system, which has been carefully evolved to diminish overactivation, and that's what we're thwarting. Well, sometimes when we thwart those evolutionary processes or these receptors, we can end up with adverse outcomes in those individuals. So our goals, obviously, for translational studies are to help identify at-risk patients, learn what the clinical risk factors might be, the biomarker risk stratification to prevent harm and mitigate risk of IO therapies, and understand pathobiology. And here's an example, which is actually one that's actually very close to my heart and an area that I think is really quite important. So Dan Barber, one of those individuals that actually is on the PD-L1 patent when I was at the NIH, was recruited to run a lab over there that focused on tuberculosis. He had been working obviously on PD-1 and PD-L1 with the interest in evaluating it for infectious disease, and TB is the pathogen that is globally offers one of the highest degrees of morbidity and problems for humankind. So he had been working actually on PD-1 blockade in mice for actually quite a long time, showing that when he blocked PD-1 and infected mice with TB, or in his case, created knockout mice for PD-1, that they tended to die faster than almost anything else that he could block or provide a knockout for. He did, what he didn't have actually was a great deal of clinical data showing that was occurring in people. Unfortunately, in our case at the NCI, we were running a couple of clinical trials in which we were able to collect samples and data and actually see that for ourselves. So we had one patient that was actually on a clinical trial with pembrolizumab being treated for Merkel cell cancer. And he developed what was essentially a mixed response to PD-1, or at least thought to be a mixed response to PD-1. And that individual had shrinkage of all his original lesions, but then ended up with a new lesion in his lungs. And so the individuals at Emory University Hospital were actually quite astute and decided to go ahead and get a wedge resection. They got this wedge resection of this lesion that had popped up, ran an AFB culture, and 6 weeks later, it came out as tuberculosis. My jaw dropped when they sent us the adverse event report as I was the monitor at the time. But then we were able to take specimens from the treatment and show that this individual, when pembrolizumab was started, did not seem to have T cells that were responsive to purified protein derivative, as proteins, obviously, from tuberculosis, this indirect measure that we use to see if the immune system is responding to tuberculosis proteins. tuberculosis antigens, but longitudinal samples along the way showed that this individual actually did respond greatly and to a relatively high amplitude of response, especially initially. And then the granuloma, necrotic granuloma, appeared in December 2015, 6 months after starting therapy. That individual then went on anti-TB treatment to ultimately to good effect. But that good effect actually required the individual to be totally off PD-1 therapy in order to have a benefit from their anti-tuberculous therapy. That's how great the effect was for that individual. Of note, the other patient that was part of this paper was an individual who had an EBV positive nasopharyngeal cancer, who died within 6 weeks of initiating therapy of a massive TB infection to the point where they were defecating tuberculosis. So this was a real eye-opener for me, and actually has led to other interests related to how tuberculosis and PD-1 might actually interact. Here's the example of that individual who unfortunately passed away I think it was, they started therapy in July, sorry, no, not July, May 2016. Here in July 2016, they were by then deceased. Now, there are different things that might actually mitigate the effect of PD-1 for those individuals that are being treated. That those can include other anti-cancer therapies. And so we've evaluated that with certain AEs that are somewhat unique and uniquely caused by PD-1. One example being type 1 diabetes mellitus, which occurs at a regular rate, maybe about 0.5% of individuals who are treated with PD-1. We took amongst the NCI trials from about 15,000 patients that were treated on clinical trials with the NCI. We looked at all the different hyperglycemia adverse event reports that were sent to the NCI Central and evaluated which of those actually truly had checkpoint inhibitor-induced diabetes mellitus. Of those, it was about 72 that myself and our lead endocrinologist Zoe Quant from UCSF were able to determine. And what we found, of course, was that there were certain combinations of therapies that led to increased rates of IRAEs of this particular IRE versus combinations that led to decreased rates. So as an example, PD-1 with CTLA-4 or PD-L1 with CTLA-4 led to about twice the rate as compared to PD-1 alone, and then giving chemotherapy with the PD-1 or PD-L1 by itself also halved the rate. So there is some effect or modulatory effect that can occur for these immune-related adverse events based on the treatments that individuals are receiving. We worry, of course, about special populations. And when I was working, obviously, for the government, that's a particular interest. Patients living with HIV, patients with solid organ transplants, and ongoing clinical trial that I'm working on with patients that have pre-existing autoimmune disease as well as pregnancy. Quick example, we were early on actually quite interested in patients that had HIV and AIDS. The NCI has been involved with AIDS research since the 1980s. It was actually the place where the first anti-AIDS drug was developed, AZT. That's obviously ongoing. And so we had two clinical trials actually that were looking at the use of pembrolizumab and nivolumab for patients with HIV, a phase 1 trial that was published back in 2019 and presented also at ASCO. Subsequent to that, a great response in those individuals that had HIV-associated Kaposi sarcoma, where we had about a 62% response rate overall. And this is a similar trial that was conducted with nivolumab and nivolumab plus ipilimumab. So it's important to note that when individuals are actually being treated well for HIV and AIDS with antiretroviral therapy, there's no reason why they can't get a response to immune checkpoint inhibitors. And that's something we advocated for both at the NCI and also at the FDA and the academic community. There were virtually no trials that I was a supervisor for that did not allow at least some proportion of patients with HIV on them. That was a mandate that we imposed on our collaborators for good reason and to good effect for our patients. Another area that's probably a little bit more difficult to justify, but still worth discussing and potentially very important are those patients that have allografts of various kinds, solid organ and transplants, that develop a cancer in need of an immune checkpoint inhibitor related treatment. So we did sponsor a clinical trial that was there that I helped design, now published in JCO in 2024 by Schenk et al., looking at the use of nivolumab individuals that had skin malignancies and renal allografts. The positive reason why we decided to use renal allografts specifically was that renal allografts can, of course, be replaced through dialysis. And so, or at least renal replacement therapy can potentially be offered to individuals even if they lose the allograft. But there was data, unfortunately, previous to this, that PD-1 in particular and PD-L1 could lead to increased risk of losing allografts. Data that has been further enhanced by real-world evidence analyses of the medical literature. So we decided to conduct a clinical trial where we were looking at the use of tacrolimus and prednisone to help suppress the immune system, but give nivolumab or nivolumab and ipilimumab to see if there might be a benefit offered. And so we conducted this relatively small clinical trial with a composite endpoint looking specifically at responses without allograft loss at 16 weeks. And so these are the results. This, again, got both presented at ASCO, I think in 2022, and then later published in JCO in 2024. The first 8 patients gave us the answer to nivolumab alone, at least with this particular immunotherapy suppression or immune suppression regimen. All the patients progressed, unfortunately, and then of those that progressed with nivolumab alone, 6 were able to then move forward with nivolumab and ipilimumab. Of those 6, 2 had CRs, complete responses, 2 of the 6, which was really quite remarkable. Unfortunately, one of those 2 patients also lost their renal allograft and had to go on dialysis, and the other actually was uniquely able to both keep their kidney, but also had a complete tumor response. Really quite interesting work, which is being followed up with another clinical trial. Another area, obviously, where we have a major interest are those individuals that have pre-existing autoimmune disorders. I'm working on a clinical trial now, also sponsored by the NCI, that I started with my colleagues Hussein Taubi and Kathy Dumbrava from MD Anderson, in which we look at different cohorts of individuals that have a variety of different pre-existing autoimmune conditions, and using their need for cancer treatment with a PD-1 inhibitor. We hope to learn to see what actually might help them from a cancer perspective, and also what effect that might have on their autoimmune condition going forward. We have over 100 patients that are enrolled in this prospective clinical trial right now, and it's ongoing and open throughout the United States and at one center in Canada. Another area that we worry about quite a lot are those individuals that have cancer during pregnancy. So we did an analysis of those individuals that were on our clinical trials, going through, at that point, about 129 clinical trials that we had conducted in the NCI-sponsored networks, of whom about there were 9 female patients that had unexpected pregnancies. Of course, for the most part, they got taken off the clinical trials at that point, but those individuals mostly actually ended up having being able to proceed to a successful pregnancy. There was one patient that had preeclampsia, but actually mother and baby did very well. And as a result of those data, I was able to provide to Dr. Andy Evans when he had a similar problem, late in pregnancy for an individual, the data that helped him move forward with treatment. So he had the unfortunate experience of taking care of a patient who had developed Hodgkin lymphoma 3 years prior to her pregnancy, and thought she had obviously done very well. And Hodgkin lymphoma generally has a fairly good outcome with standard chemotherapy. But unfortunately, this individual at 13 weeks gestation ended up having recurrent Hodgkin lymphoma. She was initially treated with the chemotherapy regimens, but at 26 weeks gestation, she was near death and had very few options available. So we gave Dr. Evans the data that we had, and then worked together to create a clinical trial in which we collected blood and specimens so that we could learn from this experience going forward. The patient was actually really quite supportive, interested in pushing forward, and ultimately did extremely well, proceeded to transplant, made the rounds in the media. Baby and mother did very, very well, and had no adverse outcomes. We got this into the American Journal of Hematology around the same time. There was a patient whose resultant infant developed a severe enterocolitis, ultimately doing well as well. But that particular case report ended up in the New England Journal of Medicine, which is something I like to tell people with IRAEs. It's sort of like local news. They sometimes say when it bleeds, it leads. The bad news gets a higher impact publication than the good news. So we were able to, of course, obtain specimens from both the patient and the umbilical cord on this resultant infant at the time of delivery, and through modeling with our expert pharmacokineticists at the NIH, we were able to determine that the maternal circulation, or the infant circulation, was likely about 2/3 of the level of the maternal circulation at its peak. Rechallenge, this is the last topic I'll talk about, is also an area of ongoing research and interest. There's actually not that much data on treatment rechallenge when patients have an IRAE. I've gone through the literature, and of those patients that get retreated, there's probably something on the order of about a 20 to 30, maybe higher percentage rate of recurrence. This is because a lot of patients who actually could otherwise be candidates for rechallenge from an IRE perspective are potentially not necessarily candidates because maybe their cancer didn't respond very well to the immune checkpoint inhibitor to begin with. And so you want to consider alternative therapies for those individuals anyway. So the data are actually kind of imperfect, and that's something that we're working to try to change. But part of the reason why data are imperfect are because the diagnosis of an immune-related adverse event is actually not all that trivial. You need to oftentimes involve subspecialty services, and there are different kinds of IRAEs, even when we do think we understand what's actually happening. So, diarrhea is a great example. Of course, there can be infectious causes and other causes caused by other anti-cancer agents that are actually being used in combination. But even within immune checkpoint inhibitor-associated diarrhea, they can have an ICI colitis, an ICI microscopic colitis, sometimes called lymphocytic colitis. You can have a pancreatic exocrine gland insufficiency. You can have celiac disease occurring as a result of the immune checkpoint inhibitor. And so it's really critical to get flexible sigmoidoscopy or colonoscopy or other associated tests to help confirm the diagnosis. And so when I think actually about rechallenge, which is a question that comes up all the time for me at Dana-Farber, we have to think about what the nature is of the adverse event, what the setting of therapy happens to be. As just an example, I'm probably less likely to suggest that we should re-challenge a patient who's being treated in the adjuvant setting who has no current evidence of disease, because the risk might be greater from the adverse event, as opposed to the recurrence of the cancer. Prior to the IRE, was the treatment effective? As I noted before, that can be actually a major reason to give, or potentially not give, rather, a therapy if the treatment was not deemed effective. So no real reason to work really hard to re-challenge a patient with therapy that didn't work for them. And then what are the chances of further benefit? Are there alternative options, meaning are there other drugs that might be available? So we treat through endocrine toxicity very commonly. That's acceptable, really only a minimal or even sometimes no pause whatsoever. But if combination IO therapy was utilized prior to the immune-related adverse event, rechallenge typically only involves one agent, usually the PD-1. So my shorthand for this, of thinking about rechallenge in general, is what's the need for rechallenge and what was the nature of the prior IRAE. So need and nature gives you an idea of whether or not you should be treating a patient with an ICI following an IRAE. What was the context of the patient's therapy, the availability of other options? Did the patient respond to prior IO? That was the need. And then nature. What was the nature of the adverse event? How difficult was it to control? And what was the immunosuppressive agent that you needed to use? Did you need to go beyond, for instance, first-line steroids? Endocrine toxicities and rechallenge, no real obvious problem there, since we have synthetic hormones that we can offer to patients, including levothyroxine, insulin, and physiologic corticosteroid dosing. And then there are rare and severe endocrine toxicities that can occur, but for the most part, those are extremely rare. And then there are things like gastrointestinal toxicity, that where there's at least a little bit more caution, so hepatitis and enterocolitis. But in both of those situations, in limited circumstances, we could consider rechallenge. Pneumonitis, I think, is an area that's a little bit more difficult. Obviously, there are patients that have thoracic malignancies like lung cancer, mesothelioma, and they can be particularly vulnerable to pneumonitis if they have decreased physiologic pulmonary reserve to begin with. We have to differentiate between some things like radiation pneumonitis or other infectious causes, and there needs to be close collaboration with pulmonary services, and potential for bronchoscopy should be part of the evaluation strategy. But again, if there is a benefit for the patient and there are very few other options, certainly rechallenge in those contexts are things that I would certainly consider. Dermatologic and rheumatologic conditions, again, probably those are a little bit more minor, and certainly can be considered in coordination and discussion with the patient. But things like myocarditis, meningoencephalitis, or severe phenotypes of toxicity, I would generally discourage. So just to conclude, immunotherapy obviously represents a significant clinical advance for patients. There are certainly some challenges that remain. IRAs are still a major roadblock to success for patients. And the study of translational immunological biomarkers can help expand access to novel therapies, especially for unique populations, avoid overtreatment, help target therapies to specifically the most sensitive patients, illuminate mechanisms of resistance to immune-based therapy, serve as a tool in drug development, and mitigate adverse events for patients and improve overall disease management. It also further can help provide insight into cognate autoimmune disease. The same molecular and analytic tools can actually be used to study both IRAs and immunotherapy response outcomes. And I would argue that every patient that's enrolled in a clinical trial, but also patients that are standard of care, can help potentially contribute to the study of immune-related immunotherapy responses and resistance, as well as IRAs. The real key is an openness to sharing and collaboration, and that can help improve outcomes and generate innovation in oncology. And I am available here for discussion.
Thank you so much, Dr. Sharon, for this wonderful presentation. Now we'll begin the Q&A session, the Q&A portion of the conference. Over to our moderator, Taha.
Thank you, Doctor, for that insightful presentation. your discussion on immune checkpoint inhibitors, its adverse effects, clinical use, as well as its application in special populations like the TB risk after PD-1 blockade, for example. It was eye-opening. Now, as you may have imagined, we have lots of questions that we would like to ask you, and I'll hand over the mic first to Raj for his question.
Yeah, thank you, Taha. So, my roots are from Southeast Asia, where the TB is like endemic in nature. For patients with checkpoint inhibitor therapy, did you find any immunological signs or, a marker or TB specific T cell response, that could predict like TB reactivation before the clinical course of the disease?
Yeah, so I we don't have that. I think that one of the problems, and certainly this is an area where I'd argue that collaboration across higher income and middle income countries actually might make a big difference, is that tuberculosis is a lot less common in higher income parts of the world. Meanwhile, although in areas like India, as an example, there is access to immune checkpoint inhibitors where TB happens to be endemic. But the access is actually fairly limited. In discussions I've had with my Indian colleagues, about 5% of patients are actually able to access immune checkpoint inhibitors, and those are individuals in somewhat more limited circumstances. So I don't feel like we have enough data at this point to have come up with any answers in this setting. Um, uh, we also, as I maybe noted, we indirectly test for tuberculosis for the most part, right? So you're doing a quantiferin gold or a PPD. What are you looking for when you do those things? You're actually looking for the immune response to tuberculosis. That's not a direct test of TB. And so that's something that makes it a little bit more challenging because in many cases, obviously, if you've had a prior infection with TB, you might actually, continue to have elevated responses to purified protein derivative or to, a quantiferin gold test. So it makes it very difficult to actually figure that out because of the long-lived memory of the immune system as to what it is that it's being exposed to. So it's a challenging area. I think that it's something that you're really quite interested actually in exploring further, and we're developing some collaborations to do so. But no, the quick answer, I guess, to your question is no, I don't have any biomarkers. I'd say the biggest issue is, whether or not individuals have a PPD, positivity, which again, from a cost-effective perspective in the US is probably not necessary, but maybe actually does make more sense in areas where TB is endemic.
Yeah, thank you.
Thank you so much for that wonderful answer, Doctor. Now, so I also have a question, and it revolves more around the use of immune checkpoint inhibitors in patients with pre-existing autoimmune conditions. So, could you briefly discuss on what strategies we would use for patients who have pre-existing autoimmune conditions, but they would benefit from immune checkpoint inhibitors, but at the same time they are at risk for immune flare-ups? So, what would we do in such a situation?
Well, ideally, I'd like them on my trial, but because it's an ongoing clinical trial, we're trying to learn more about those individuals. I think that, for the most part, we have been successful in being able to administer these drugs to individuals that have pre-existing immune checkpoint, or sorry, autoimmune disease. And there are case series that have been reported. The reality, of course, is that the patients should be aware of the risk. The patients also need to be have available to them their rheumatologist or gastroenterologist or other individuals, neurologists in the case of multiple sclerosis, who might actually be able to assist them if there's a flare of their autoimmune disease. The point I would sort of make, and I don't have the numbers as of yet, but is that um, uh, since immune checkpoint inhibitors themselves are actually kind of global, right? So they're globally affecting that immunoregulatory machinery. It's not simply in the context of that autoimmune disease that the patient could be at greater risk. They could, for instance, if even if they have multiple sclerosis, they can still get ICI-induced colitis. They could still get a hepatitis. There's no protection, in other words, that they have, which makes it so that they're only likely to get an exacerbation of their autoimmune disease. So I think all those things need to be told to the patient in context. And if the best option is still remains the immune checkpoint inhibitor, it just requires coordinated care with the autoimmune disease specialist in conjunction with the oncologist.
Thank you for that answer. It's interesting to know how multiple factors play a role in management of in these special populations, I would say. Thank you for that answer, Doctor.
Absolutely. Thank you.
Yes, so hello, doctor. Thank you so much for your presentation. So my question is more related to like PD-1 inhibitors, which you mentioned towards the beginning of your presentation. So what exactly is your take on personalized new antigen vaccinations in combination with PD-1 inhibitors? So are we close to making them a clinical reality?
It's a great question. I know the data, from the trial that was sponsored by Moderna and Merck that has been presented. They have an ongoing phase 3 trial. I haven't heard anything in terms of results of that effort as of yet. So that is still obviously an open question, and we just need to wait for the analysis or for the company press releases, as it were, to see if that is an area that shows a benefit. It certainly makes sense. It's made sense for some years. Some of the tools that are now available are actually really quite impressive. And Kathy Wu, who's a researcher that I work with very closely, Patrick Ott, another colleague of mine at Dana-Farber, both of those individuals have been really closely involved and have had really remarkable publications recently. And so I do think that there's a chance that this could work. We just need to await the rigorous clinical trials to end up giving us an answer and see what setting there's the best effect for these new therapies to provide benefit to patients.
Yes, that makes sense. Thank you so much, doctor. I look forward to reading the publications once they're out.
Absolutely. Yeah.
Thank you so much, Dr. Sharon. It was such an amazing keynote and it was truly enlightening. I really quite enjoyed it. So my question is, you've worked closely with both academic institutions as well as the industry. So I was wondering, what do you think are some of the key ingredients in a successful partnership between a private and a public entity when it comes to oncological drug development?
Yeah, I do think that there's a lot of opportunity available if we create structures, and certainly I think that that's what is necessary in order to calm the nerves, as it were, of all the players. The benefit of actually having the government sort of serve as a neutral third party and providing, a framework so that innovators, which, essentially in the case of industry, they own intellectual property. In order for them to make their investments, they have to feel that their intellectual property is actually protected. And so the success that I think the NCI has had has been framed around that structure, essentially allowing industry partners to utilize the academic networks that are also partially funded by the U.S. government in order to allow them to both access great individuals, remarkably intelligent and collaborative researchers, while protecting their IP, their intellectual property. And so that certainly, I think, is an important aspect. Of course, not all the trials that we did when I was at the NCI, not all the trials that we conduct in general involve industry, but in order to get industry involved, there has to at least be some care taken so that they have an ability to protect that IP.
Thank you so much, Doctor. I think it's right what they say, collaboration is the only way to drive cancer research forward. So thank you so much for that.
Agree 100%.
Thank you, Doctor. Um, I have one more question for you. So for our junior attendees who are just starting to get into research and the field of medicine, what inspired you to pursue the field of your field of choice? And also, how has this choice impacted your life? And did you achieve everything that you had initially anticipated?
Well, I'm not here to retire. I still feel quite young, but I would say that unfortunately, as a young medical student, I lost my mother to cancer, and that certainly pushed me in a direction that I wasn't necessarily seeking initially. I think that it certainly affects us greatly to have loved ones who are ill, many individuals who are taken care of, in healthcare actually have those as primary motivations. But really, there's a lot of humanity that healthcare requires. And in order to, I think, be a good clinician, a good healthcare provider, a good physician, I think it really does require being able to identify with your patient and being able to identify and realize, of course, that we're all human. We're all going to be in these situations ourselves in the future, and if not that, in the that our loved ones may be, and so compassion is actually a major part of I think what drives many people both in the research field as well as in the direct clinical care.
That was a really sad story, Doctor, and we appreciate the opportunity to learn from you and also your important work. And I just have a final question for you. With everything said and done, what do you still hope to achieve in your career, and what do you want to be remembered for?
Well, I hope that I'm useful to obviously the drug development community. I think that I still care quite a lot about immunotherapy in general. I think we can do more than we're doing globally for individuals, both in expanding some of the efforts that we've had thus far to other parts of the world, but also in improving outcomes. In oncology, I'd say that we have grown a little bit complacent sometimes. FDA approvals occur when we say that there's a benefit shrinkage of tumor sometimes with just a minority of patients, right? So 20% response rates to 30% response rates is a remarkable advance for some tumors. And it's hard to deny that that's the case when you think about the fact, for instance, that until 2011, there have been 0 approvals for melanoma since the 1980s in the US. So 1980s to 2011 is a long time, and those individuals were actually doing quite poorly throughout that period. But when you look at the numbers, you still realize that despite the fact that you might be able to get a drug approval, despite the fact that you might actually be able to get something that you say, oh, how wonderful, this works. We're still at the point where only a minority of patients are benefiting for many of these solid tumor approvals that we're actually able to discern. So we have to do more to actually determine who those patients are. And I think that it's also important, part of the reason why I focus on immune-related adverse events and why so much of the research that I'm initiating here is in that area, is because in doing all these treatments, we're also causing harm. And we have to learn more about how to treat, manage, mitigate, prevent that harm in order for patients to really benefit. And so, I guess I've sort of focused my efforts on making sure that no one's left behind. That's why I talk about those patients who are pregnant, those patients that are that have autoimmune diseases, those patients that have renal allografts or other solid tumor allografts. All those individuals also need our attention in the medical research community, and there's a lot of work to be done in order for us to advance the field and advance the cause of human health. So I think that at least from my perspective, there's a lot to do. I think that there's a lot that I hope to be able to achieve, but there's a lot more of work to do, and I'm certainly not one of those individuals who rests on my laurels. I think there's a lot that we have to focus on. That I understand what the work is, and I'm eager to contribute to it.
You, Doctor, for that response. Getting to know more about immune checkpoint inhibitors and its clinical use from you has been a great honor. And we would
Thank you
again
so
like
much.
to we would again like to thank you, Doctor, for this amazing session. We would also like to thank everyone for their questions and all of our attendees. Um, Please continue to follow MedNewsWeek on all our platforms to follow up on more upcoming keynotes. Thank you, everyone.
Thank you. Thanks again for the opportunity. Really appreciate it.